Welcome to part two of Block 1 podcast on airway equipment. I'm going to start this section on video laryngoscopes. I recommend chapter 25 from textbook by Benjamin and Hagberg. And briefly, this technology was developed in the beginning of 2000s, and a couple of early laryngoscopes that had the ability to show the glottis on a screen or through a light tube or such. Included the TrueView and the McGrath. If you look at the McGrath MAC, it looks just like a Macintosh blade. Video laryngoscopes have evolved to have highly curved blades, such as found on the Glide Scope and on the McGrath Series 5 and the AP Advanced Difficult Airway blade. The primary benefit of these highly curved blades is with a camera on the end of the blade is to be able to see around corners. And as you are all aware, having used glide scopes, the use of a shaped tube which directs the shaped introducer directs the tube into the glottis, and then under direct vision the tube is advanced. Now I've copied the conclusions from the chapter, and I think it's worth reading these carefully and thinking about the purpose of video laryngoscopy. And it starts off contrasting direct laryngoscopy, which is what we normally do, with the new technology. So direct laryngoscopy for intubation gives the advantage of familiarity and direct glottic visualization, cost effectiveness, and ready availability, and a steep learning curve. That means that you actually learn quickly. A steep learning curve is a curve where you acquire information, you acquire skills quickly. However, you have all seen grade 3 views at direct laryngoscopy, and they are persistent. And the basic airway maneuvers such as external laryngeal manipulation and head lift, which which is what you do when you do laryngoscopy. You actually lift the head up off the pillow most of the time, and together with accessories such as bougies, still remain crucial to the success of an unexpected difficult direct laryngoscopy. Now, alternative intubation techniques such as video laryngoscopy are essential to achieving success in challenging situations. The video laryngoscopes like we have, the Glide Scope, are mobile and quick to set up and can be used in the management of an unexpected difficult airway. The use of a video laryngoscope in a predicted difficult airway, if mask ventilation and oxygenation are warranted or in situations where blind techniques are contraindicated, or if you want video documentation of the airway, um, those are uh, situations where a video laryngoscope can be particularly useful. However, I think you should always remember that the gold standard for the management of a predicted difficult airway when oxygenation after induction cannot be ensured is the use of flexible fiber optic device in an awake, spontaneously breathing patient. That's the bottom line when it comes to airway management, and that's the conclusion in that chapter. There's much to be gained by reading that chapter. However, it it's obviously quite easy to learn how to use a video laryngoscope such as the glide scope. It's deceptively easy. It's unfortunate that if a learner becomes very dependent on video laryngoscopes, they may not develop the skills of a consultant anesthesiologist who can manage a difficult airway in the absence of the modern technology. Now, changing topics, moving on to endotracheal tubes. First, I'm going to bring to your attention that the first endotracheal tubes were made of a red rubber hose and were cut from a roll. Were pretty irritating, in fact. And over time, it became important to develop materials that were less irritating. So now we have PVC tubes that are implant tested and shown to be fairly inert. We can divide endotracheal tubes up into single lumen tubes and double lumen tubes. First, single lumen tubes can be cuffed or uncuffed. They can have low pressure cuffs or high pressure cuffs. The tubes can be oral tubes, nasal tubes, or oral/nasal tubes. A lot of this has to do with the radius of curvature of the tube. There's small differences in the optimum radius of curvature of oral and nasal tubes. There are special endotracheal tubes, which are referred to as anode tubes or flexometallic tubes, which are the wire reinforced tubes that you have seen used in head and neck surgery. There are preformed oral and preformed nasal tubes. These are trademarked RAY tubes, stands for Ring Adair Elwin, which are the names of the three inventors of the preformed RAY tube. There are preformed tubes which have other names such as North Polar and South Polar, made by Portex. There are Parker tubes, which are somehow or other designed for manipulation and at the time of intubation. They're not a tube that I have any experience with. We do have them on order, though. There are tubes which are laser resistant or laser proof, and which are used to provide anesthesia in the presence of laser beams. And of course, all these tubes have recommended instructions for use, and sometimes they're not entirely intuitive. So even though you're used to putting in endotracheal tubes on a regular basis, when you come across a special tube, you might well want to read the instructions for use, because they may well be different and separate, special. Some other special single lumen tubes include those that are made of a fairly opaque material called Portex ivory, or it's the same material that you see in some nasal airways, kind of a bluish white material, very soft, very atraumatic. I've not seen any in the UK here, but I've used them in other countries. There are silicone tubes, which are quite inert, or microlaryngeal tubes, which are used for adult microlaryngoscopy, microlaryngeal surgery in adults. And they're very small diameter, but adult length. And the next slide will show a comparison between a pediatric tube and a microlaryngeal tube. Double lumen tubes are outside this podcast, and if you're interested in seeing what kind of endotracheal tubes are available, I recommend that you Google the Portex catalog, and you'll find there's a much larger selection of endotracheal tubes in the market than you see here in the UK. This slide shows the contrast between a pediatric tube and a microlaryngeal tube of about the same size, and not surprisingly, the adult microlaryngeal tube has a larger cuff on it and is longer. Endotracheal tube cuffs should be inflated to a specific pressure. In other words, they should be inflated enough to seal the tracheobronchial tree from the gastrointestinal tract. And we do that by listing for a leak, but a more quantitative way of adjusting the pressure in cuffs of endotracheal tubes is to use a cuff pressure gauge. And this slide shows a picture of a cuff pressure gauge, which is usually found in the hands of respiratory technologists. So as the slide depicts, the purpose of a pressure gauge is to measure the pressure and control it in high volume, low pressure cuffs. The use of low volume, high pressure cuffs is not recommended, although some tubes function that way. And if you put a small tube in a large airway, even a high volume, low pressure cuff can become a high pressure cuff. High pressure cuffs risk pressure necrosis and mucosal ischemia. And underinflation, of course, can lead to the risk of aspiration, silent aspiration. Now moving on to tracheal tube guides and introducers. This slide shows what some people call a stylet in a straight to cuff configuration, and quite simply the curved endotracheal tube is now shaped into a hockey stick shape that is straight to the cuff, and then with a pretty sharp bend on it that you can direct when you do laryngoscopy. I'll bring to your attention that this particular stylet for intubation is quite a lot thicker than the ones we're used to, and is actually quite it's quite malleable. It's made of aluminum and is coated with plastic. It may well be a little bit slicker than the wire that we use here at UK. Anything that you put into a plastic tube and which is bent at a 90-degree angle will be a bit sticky pulling out. So lubrication with a non-water-based lubricant might be a good idea if you want to be able to pull the tube out with ease, pull the introducer out with ease. This slide shows a number of tracheal introducers, and the item at A is a Eshman introducer, and as the legend says, it's also known as the gum elastic bougie. It has a coude tip, or a bit of a curve to it, and is solid. It does not have a hollow core, and an Eshman introducer is meant to be used and reused and re-sterilized. Item B is a hollow Frova intubation introducer, and we do have those at UK. There is an optional internal cannula that makes it somewhat stiff, and of course this intubation introducer will fit through a tube. Item C is a SunMed endotracheal introducer. I think it's the same brand that we have here at UK. And the item D is a Cook Airway exchange catheter, which some people call a banana. Although some bananas are solid, this banana is hollow. Now, I bring to your attention the Cook Medical Difficult Airway Catalog, and in that catalog you'll find such things as an Aintree, which we have in stock at UK, and it has a 19 French outside diameter and a 4.7 millimeter internal diameter. It is an airway exchange catheter. Since fiber optic bronchoscope has an outside diameter of 4.2 millimeters approximately, some may be smaller, a bronchoscope can be inserted into an Aintree, and sometimes in concert with a laryngeal mask airway can be used for intubation. I recommend that you read the instructions that are provided with any airway equipment, because sometimes there are not quite intuitive nuances in their usage. As shown on a slide, two slides back, the Frova is a proper endotracheal tube introducer. Comes in two sizes. I believe we have only the larger one here, and it is used for inserting endotracheal tubes. It does have the ability to deliver oxygen through the center of the introducer by the RapiFit connector, which is shown on the end of the catheter here. I show this picture for a couple of reasons, and this shows the use of an endotracheal tube introducer. Looks like an Eshman, and it comes from Up to Date, and the person who is responsible for this photograph is on faculty at Dalhousie University, which is where I trained. This video here shows the use of the gum elastic bougie to guide the endotracheal tube, And one of the things which is typical of gabalastic bougie is the sensation of the uh, uh, tracheal rings. As that bougie is advanced into the trachea, you can feel the tracheal rings, and that's a, a pretty good indication that you are um, inside the trachea. Um, this is the old-fashioned way of uh, inserting a tube in it when you cannot see the laryngeal opening very well. It may well be uh, supplanted by the use of video laryngoscopes, but if you don't have a video laryngoscope, you have to still get the tube in. Another airway device which I've never seen or used, but I present to you on this photograph, is a intubation pillow. And while it may not be perfect for everyone, you can see that it does elevate the occiput quite significantly, probably as much as you should for a true sniffing position, which is on average about 4 inches or 10 centimeters. And as indicated in the legend, the pillow that's demonstrated on this slide um, does does flex the cervical spine and creates a certain amount of atlanto-occipital extension. And the theory behind this is that it aligns your laryngeal and pharyngeal axes. And if nothing else, it helps lift the patient's head off the pillow, and some patients have quite heavy heads. Because I've decided to divide this podcast up into bite-sized pieces of about 20 minutes, I'm going to stop this portion here, and part 3 will cover a few more topics.